Peace.
I'm tougher than rock. Said I'm black. I'm tougher than rock.
WHCR 90.3 FM, New York.
A worldwide epidemic of ignorance and hate has infected people of all faiths and colors, poisoned them against their sisters and brothers, yes.
Good evening, ladies and gentlemen. This is Sean Shivers, and I am back for our second segment of Health in Harlem on WHCR 90.3 FM, New York, the voice of Harlem. I was a little scared for a moment because I was about to play our music, and I wasn't sure if it was going to play, but I'm actually glad that it did. Our guest tonight is Dr. Herman Anderson, and he is an attending physician, and he also works in the nephrology department, and he also specializes in emergency medicine. And we are talking about kidney disease, renal disease, how to take better care of two organs in your body that sometimes people take for granted. That is your kidneys. So again, I thank you for coming on the show, and we're just going to continue off where we left off at. Now, I had mentioned earlier that kidney disease really affects the African American population. So, Dr. Anderson, can you continue with that piece of?
Sure. First of all, there are a higher percentage of African Americans that are afflicted by chronic kidney disease. It's actually 4 times that of whites in terms of the proportion of the population. We have a tendency to develop kidney disease at an earlier age, and as I explained the different stages, we will progress through those stages at a lot faster rate than any other ethnic group. But interestingly enough, the survival of whites as they progress from stage 1, 2, 3, 4 is less than it is for African Americans and Hispanics. The survival is higher, and also on dialysis, blacks have a tendency to live longer on dialysis than Caucasians. So we do have the longest survival of the end-stage renal disease population. Now, with each stage of chronic kidney disease, where you're filtering less and less blood, so you're retaining more and more of these chemicals in your body, it's almost like a woman who wants to kill her husband. She puts a little strychnine in the food every day. Not enough to kill him at once, but just a little every day.
It's a one analogy.
But this is a way the chemicals kind of build up over time. So kidney disease starts out as it's insidious. It doesn't really cause you any symptoms. It's just like we used to what we say about hypertension is a silent killer. So and it also is hard to detect. For instance, we said that the kidney early on will filter about 3 to 4 ounces of blood per minute. Well, if you think about the amount of blood coming through the kidney for it to filter, we get about, say, roughly a pint coming through a minute. Now, when that when that pint comes into the kidney, there are about 1 million little filters in each kidney. Now remember, the kidney is the size of your fist. So there are 1 million filtration units in each kidney, and these are little blood vessels, little crops of blood vessels. So as the blood goes through that little vessel, the chemicals leak out and it's collected in a system of tubes. Okay? So now, if you were to take that pint, that blood would distribute among 1 million small microscopic filtration units. Now, if you were to lose half of your kidney function, if you lose half of those filtrations, now you'd have twice as much blood going to each little filtration unit. All right. Now, they would initially expand and accommodate, so you really wouldn't lose that much function because they increase their function to cover for the ones that are lost. But the process of adapting to those units that have lost would eventually damage the ones that are adapting, and over time they would become damaged because of the high pressure filtration. So it's like the difference between, say, a water hose. I know this is up north, so people may not know what a water hose is.
Yeah, I know what water hose is.
You're watering the grass or something in your plants.
You're right.
Compared to the water, the pressure of water going through a fireman's hose, that can rip the paint off the wall. So once you get a certain amount of pressure coming in through those filtration units, they get damaged. And there are certain things that will accelerate that damage. Number one is high blood pressure. High blood pressure will accelerate that damage. That's why we really focus on trying to control the blood pressure.
And also, I'm reading right here, as far as my notes, it says high blood pressure, and I think I said that earlier, but high blood pressure is the second leading cause of kidney failure among African Americans.
Yes, yes. And there's I think we talked about this 2 years ago. There's a reason for that. In other words, if you take blood pressures and you compare that to the blood pressures of African Americans and Hispanics in the Northeast, who have a lot of African ancestry and mixture, and you compare that to Asians and Caucasians, the same levels of blood pressure will cause more kidney damage in peoples of African ancestry. And there's a percentage, a subgroup of people that even if you control the blood pressure perfectly, the kidneys are going to still progress at a rapid rate to end-stage kidney disease. And we'll talk about that, the genetic part of that later.
Well, can I ask you a quick question?
Sure.
Talk about genetic part, and this comes down to clearing up some myths and misconceptions. Growing up, I've always heard that African Americans have high blood pressure because of what they eat. They're always using fat back, and they put salt in everything, whatever, and that's the reason why a lot of us have high blood pressure. Is that truth, or is that a fact, or is that just a myth?
Well, let me put it this way. If you compare, say, a black hypertensive to a white hypertensive, roughly half of the black hypertensives, their blood pressure is going to be salt dependent. Okay? So restricting salt and using water pills to get the excess salt out will go a long ways to controlling that blood pressure. Whereas if you take white patients, the majority of them, 50%, are not salt-dependent hypertensives. Their hypertension is related to certain hormonal imbalances. Now, so we have different things that contribute to high blood pressure, some of which are related to an environment, what we eat, the stress in our lives, things of that nature, and other are related to genetics or heredity. Now, there is a theory that this is a selection process. So in the continent of Africa, people who have different levels of salt retention. All right, but you'd have to have some salt retention, or you sweat to death.
Correct.
Okay, you lose all your salt, you get dehydrated and die. So during the Middle Passage, during the crossing over the Atlantic, the enslaved people were like cattle, and it's a business. So if you're moving cattle, when you get to the end of your journey, you're going to have to account for every steer, because everyone lost his money. All right, and these records were kept on slaves. Okay, enslaved people. All right, so there was a researcher that went through this data and found that the majority of people that died on the way over died from conditions that relate to salt and water loss. So it was diarrhea, dysentery, things of that nature. That's what was cataloged in the cause of death of the commodity that they considered, that they were in charge of. So the theory then was that, okay, well, all of those who couldn't hold on to who weren't strong salt retainers, were more susceptible to dying during the course of transport. Then, once they got here in a southern hot environment, one of the main reasons, say for instance, the Indians were not good in the type of work, was that they died from sweating and getting dehydrated. They couldn't take the temperature. So again, you had another selection process here. Everybody else, the strongest salt retainers were the ones that survived. Okay, so now you have a population of people that have a higher percentage of salt retainers, and when you start increasing the salt in your diet, then that will contribute to the rise in the blood pressure. So that's one of the theories that has.
No offense, but you would never hear anything like this in the history books. I thank you for explaining that. I've never heard it explained like that before, and it makes so much sense, and it's so interesting. Thank you.
Now there are some other when we come to kidney disease now. We find that even though there's a much higher prevalence of hypertension in the black community, not everybody progresses to kidney disease. All right, but there's a subset that will progress regardless of what you do. Okay, and that's genetic. And we kind of talked about this to a certain extent the last time about the apolipoprotein L1 gene. And that, since we talked about this before, that has been so much more data on that confirms that this is the main cause of rapidly progressive kidney failure in the black community, and in, as I said, the Hispanic community in the Northeast, like Puerto Rican, Dominican, who have African ancestry. Because if you look at Mexicans, this is not the case. All right, so again, this was a gene that evolved over what's considered roughly 10,000 years, and its purpose was to kill the parasite that caused African sleeping sickness. So it carries a gene that can be found in the kidney, in certain cells in the kidney, and the vascular lining, and that gene makes a protein that lyses or kills that parasite. All right.
So, on that note, I want you to hold it because that's very interesting. We're going to go to commercial break real quick. You're listening to Health in Harlem on Whcr 90.3 FM, New York, the voice of Harlem. Again, we're going to take a quick break, and we're going to come back with some more valuable information. So, please stay tuned.
WHCR 90.3 FM, New York.
The world-famous Apollo Theater invites you and your family to the second annual Harlem Healthy Soul Festival, Saturday, September 13th from 12 p.m. to 6 p.m. It's free fun for the whole family with live music, food and exercise demonstrations, health screenings, games, and so much more. Performances and appearances by Dr. Ian Smith, Faith Evans, Dr. John Palmer, the Nick City Dancers, and DJ Big Tigger. That's the second annual Harlem Healthy Soul Festival, Saturday, September 13th from 12 p.m. to 6 p.m. This event is free and open to the public. For more information, visit www.apollotheater.org. Sponsored by Coca-Cola and Emblem Health.
Hi, I'm Vinny B of the Vinny B Showcase. Tune in every Thursday from 8 to 12 midnight for some solid cultural roots music and some sweet lovers rock. Also, informative interviews and giveaways. Right here on the Vinny B Showcase every Thursday, 8 through 12 midnight on Whcr 90.3 FM. Peace.
I'm tougher than rock. Said I'm black. I'm tougher than rock.
WHCR 90.3 FM, New York.
Good evening, ladies and gentlemen. Once again, this is Sean Shivers. Oh, I forgot. My boy knows that. I'm sorry. Y'all can get ready. This is Sean Shivers.
And Mo Selby.
You know what? We had to figure out how to do that when you're sitting over there and I'm sitting over here.
That sounds like a plan.
Okay, no problem. Listen to Health in Harlem again on WACR 90.3 FM New York. And our discussion tonight is, our guest tonight is Dr. Herman?
That's right.
Herman Anderson. He is the attending physician, and he also works in the nephrology department at Harlem Hospital, and he also is a specialty in emergency medicine. And we're talking about
One of my favorite guests.
I'm just going to say end-stage renal disease. We're talking about kidney disease, and we're also talking about the kidneys, how they work, how they function, and what we need to do to take care of them.
True story.
I would go back and I will summarize what we're talking about, but we said so much information that I'm not going to be able to. But what I would like for you to do, Dr. Anderson, is continue where you left off at. And I think you're talking about genetics. The genetics.
Oh, yeah.
Mm-hmm.
Yeah, I wanted to draw the parallel. You know, most diseases have a genetic component and an environmental component.
Mm-hmm.
All right. Now, the environmental component is something that we can influence. The genetic component, we can't influence.
Mm-hmm.
And the impact of the genetic component depends on how strong the gene is. Okay. And usually the genes will have a couple of genes that work together. So if you have half of one, you have less problems. If you have both of them, you have a bigger problem.
Mm-hmm.
Okay. So when we look at this ApoL1 gene in African Americans, let me just give this a little background. I remember when I first came to Harlem to work at Harlem Hospital. It was in '83. And we had a lot of kidney disease due what we call heroin nephropathy. So, and these were the IV drug users.
Mm-hmm.
Okay. And it was enough, we published papers on it, did kidney biopsies, and this is heroin nephropathy. And then all of a sudden, the AIDS epidemic came. Then all of a sudden, we didn't see much in the way of heroin nephropathy. It was still there, but then we started seeing HIV-associated nephropathy.
Yes, sir.
And that would hit the person they would get kidney disease, and they would be from normal kidneys to end stage within a month or two.
It's insane.
All right. So, and after a few years, the percentage of people on dialysis, the largest percentage between the age of 25 and 45, the majority of those patients had end-stage kidney disease due to HIV.
So I have a quick question, and just because I don't have a medical background, and I want you to clear this up for me. So you had said at one point, I guess individual who was taking heroin, you said it called
heroin-induced nephropathy.
Got you. And then you had said that then when the AIDS epidemic came out, so what happened? So why is it?
Well, one of the big reasons in this in our community was a transition from heroin to cocaine. And the socio-behavioral, environmental effects, aspects of cocaine abuse versus heroin abuse. There was a study done by the State Department in New York, and they looked at a group of prostitutes. And one of the part of the cohort were heroin using prostitutes, and the others were crack using prostitutes. Okay, and they found that there was a low rate of HIV in the heroin prostitutes, but there was a very high rate of HIV in the crack prostitutes. So when they looked at the behavioral aspects of this, they found that the heroin prostitute would get up in the morning once she woke up, wash up or get some clothes, get something to eat, go out, turn a couple tricks, get some money, come back home. You get their drugs and nod out. That was basically. The crack would be in the crack house turning tricks all day long because the high was real quick and it ended. So they had to continue. So the contacts, the amount of contacts they had in the crack house, the exposure was greater. It's just like the male homosexuals in the bathhouses. You just had lots and lots of contacts, so you could circulate the potency of that agent. But the thing is, it took over from the heroin. It was a more addictive drug, and people started moving towards that. So then a lot of papers came out about heroin. It was a very similar biopsy. If you took a biopsy of that kidney, the kidney, the tissue looked similar, very similar. It's the same
in terms of the damage done.
In terms of the how you classify the damage, it was like focal parts of it that would be scarred. Okay, and it was called focal segmental glomerulosclerosis. All right. So, but the thing about the genetic, so that's an environmental aspect.
Yes.
The thing about the genetic component is there were a lot of people who had HIV, but why was it just blacks who were getting HIV nephropathy?
And that's where the genetic component.
And that's when the genetic component came in. So now, once they've sequenced that, now they know where this gene is, and they've looked at the components of this gene, and then looking at the fact that we always knew there was probably some genetic aspect to kidney disease in the black community, because you would have families where people would have a lot of different relatives that had kidney disease, but there would be different kinds of kidney diseases. Somebody might have lupus, somebody might have sickle cell, someone would have diabetes, someone would have high blood pressure, someone would have what we call these glomerulonephritis or other causes. So the fact that everybody, because even though it was different causes, they ended up getting kidney failure, made you think that maybe there was some heritable.
What can I ask this question? And this is just someone again who doesn't have that medical background. Is that when you talk about kidneys, you're talking about the filtration of the blood.
That's
so
right.
My thought process right now is that an increase of diabetes is because of the fact that your body cannot filter the glucose out of your blood, so that's why there's an increase in diabetes, and that's why, or any type of disease that relates to your body not able to filter out the blood.
Well, now you're getting there.
Okay.
Now, again, if we go to the genetic environmental component, you see there's a epidemic in diabetes now. In children.
That's right.
That's an environmental factor. I mean, with the fructose and the glucose and everything, and that's an interesting political story there, because with the obesity and the diabetes, this has been kind of worked out. That's why we've seen this big increase, and the Senate and then the Congress had the Department of Agriculture to look at this. They came up with some recommendations on cutting these sugars and fructose out of the food products, and the fast food company lobbied, and they had a powerful lobby because they'd already cut back on the cholesterol and the salt.
Trans fat.
So in order to make the food taste good, you added more sugar. And the lobby was so strong that they had to can those recommendations.
Wow.
So, and if you look at the nutritional information on which is mandated that every product that's sold, food product, has a nutritional information. If you look on that, they'll have the percentage of what is your daily requirement on every component except for sugar.
You're starting to sound like Dr. Culpeper Morgan. She's starting to sound like you. Yeah, very deep right now.
So, that's politics.
It's politics. There's always politics behind this stuff. But the thing is being aware of it, and this is something that I'm just learning because I realized that you have the percentage of protein, for your daily value, potassium. They got them all for all the other nutrients and micronutrients, but for the sugar, the biggest component, pretty much, there's no value there.
You'll see under there they'll have percentage of carbohydrate, but under that they'll have sugar. And there's no percentage. That's the only one that doesn't have a percentage.
Wow.
Well, you know what I want to do right now.
Just in terms of the diabetes, though, so there's an environmental and some genetic components.
Yes.
But getting back to the genetic, if you take diabetics, hypertensives, and people with HIV or sickle cell, if you look at the ones that end up with kidney failure, and the ones that don't, you'll find the gene in those that do. So there are certain things you can have that gene and it can lay dormant, but there's certain things in the environment, especially immunologic, inflammation, viral infections, things of that nature, that can trigger or upregulate that gene, and then it becomes manifested in the person, and they have accelerated kidney failure.
Very, very, very interesting. What we're going to do is that we're going to take a very, very quick commercial break because I want to come right back and continue where we left off at. You're listening to Health in Harlem on WHCR 90.3 FM New York, the voice of Harlem. We still have 15 minutes left, so if you have any questions, comments, or concerns, hit us off 212-650-6903. That's 212-650-6903. Again, we're going to take a quick break, and we will be right back.
WHCR 90.3 FM, New York.
Hi, I'm Vinny B of the Vinny B Showcase. Tune in every Thursday from 8 to 12 midnight for some solid cultural roots music and some sweet lovers rock. Also, informative interviews and giveaways. Right here on the Vinny B Showcase every Thursday, 8 through 12 midnight on WHCR 90.3 FM. Peace.
I'm tougher than rock. Said I'm black. I'm tougher than rock.
WHCR 90.3 FM, New York.
We need a healing. Open up your heart. Open up your heart. You know the world is going insane. There's so much hate and pain. We need a healing.
Sorry, I'm
Good evening, ladies and gentlemen. This is Sean Shivers, and over there's my boy
Maurice Selby.
We gotta do it like that.
Maurice Donovan Selby.
We'll do it like that.
Name. All right, there we go.
We're perfected. You're listening again to Health in Harlem on WHCR 90.3 FM, New York, the voice of Harlem. And we have Dr. Herman Anderson. He is an attending physician and he's also a specialty in emergency medicine. And we are talking about kidney disease. Now, we have a caller on the line, and I know the caller hears us, so I'm about to put you on the air automatically right now.
On the air now, okay?
Yeah.
Hold on a second.
Caller, you on the air? You hear me?
Yes, I hear you.
How you doing? What is your name and where you calling from?
I'm Sister Mary, and I'm calling from Harlem.
How you doing, Sister
And I
Mary?
listen to your program. It's very interesting.
Thank you very
I
much.
want to know if you give dialysis to people in your hospital.
Dr. Anderson, can you answer that question?
Yes, actually, right now we dialyze about 88 patients, and the hospital is planning on expanding doubling that. We've had in the past 2 years, we've actually been the first public hospital to be cited in the U.S. News and World Report Best Hospitals for our dialysis unit.
Wow.
Yes.
We've
That's what I heard. Yeah.
right. So yeah, we do dialysis. We do hemodialysis. We used to do peritoneal dialysis, and we actually did that during the height of the intravenous drug epidemic, because people didn't have blood vessels to create accesses for dialysis. So we did peritoneal dialysis, and because people didn't have the housing situation where you could store a month of bags, we would do it as inpatients. So they come in and stay in for 2 days, and we do peritoneal dialysis. That's not the way it's done now, but we did that because we had to. But now, there are different modalities. You have in a unit, you can get dialyzed in a unit. You can. The government will also pay for home dialysis, for either home hemodialysis or home peritoneal dialysis. And as I said before, it'll also pay for transplantation.
And also, Dr. Anderson, isn't it true, and I could be wrong, that the way they have it set up at Harlem Hospital now is that when you're getting your dialysis, you do not have to sit in the room with a bunch of other people. You can have your own little cubicle, own little privacy, I heard?
Well, I could be wrong, but that's going to be in the new section.
Got you. Okay.
Everybody does have their chair, their machine, and their TV.
Okay.
And there's the state or the federal government regulates how close people can be. So people have a certain amount of space around them right now. But
Gotcha.
yeah.
Did we answer your question?
Yes, and could I have the telephone number to the dialysis in Harlem? Because I know if someone would like to know more.
Sure. Yeah. You have anybody's hand? You have a number?
Sure. It's 212 939 939 4848.
4848.
Got you.
Thank you so much. This is a very interesting program.
Thank you, Sister Mary.
Sister Mary, I thank you for Sister Mary, I thank you for calling in.
Good evening.
I greatly appreciate it. Thank you, ma'am.
Have a good night. So this is heavy stuff, man. And
I love
about
this.
the genetics
Helping the
behind
community.
this. It's scary to me because speaking of dialysis, right? You have these huge machines, thousands of dollars worth of equipment. People being dialyzed 3 times a week, 4 hours each time, and your kidneys do this if they're functioning correctly every day, all throughout your life, filtering your blood without you even knowing it.
Right.
24/7. So it's scary thinking about being susceptible to losing them. And I was just briefly, when we took that break, I was talking to Dr. Anderson, like, sometimes I'll see a little bit of foam in my urine. I know I'm getting a little personal, but anyway. Foamy, but that's an indicator. Okay. That's a sign that it could be protein in your urine.
Oh, got you.
But it's just scary being an African American, knowing this history, knowing the genetic risks associated with this. It makes me worry a little.
Don't you normally have foam in your urine a lot of times too? not saying you was drunk or drinking alcohol, but like if you drink alcohol or you drunk and you go to the bathroom.
Well, actually, no, that's probably because of how much volume you're putting out.
Oh, okay, all right.
You know, because people, you know, when they're drinking, they're partying or they're having socializing and they hold it.
That's
And
right.
when they go, it's a lot of volume. You know, there is a pathological foam, and it bubbles up and it stays. It doesn't just go away. The bubbles stay. And see, the protein we lose is like the egg white protein. Okay, and then it will bubble up. Now, this is an important point, because when we talk about kidney disease, remember we said we start off with stage 1, where we filter about 4 ounces of blood, and then at end stage it's a half an ounce. It's down to a half an ounce.
Wow.
Now, so there's 5 stages that you go through. Now, if we were to look at the issue of why people progress fast, there are some factors that outside of genetics that cause people to progress faster than others.
So environmental things we're talking about again?
Yeah, we're talking about one of the 2 factors that your doctor would notice would be whether your blood pressure is elevated and whether you had protein in your urine. Those are 2 big ones. And most of our treatments in terms of trying to slow the progression or prevent are centered on those 2 issues.
Yes.
So can I ask a quick question? And you can finish. So basically, Dr. Selby and Dr. Anderson, you're both saying that if an individual goes to the bathroom and their urine and you see foam sitting on top of your urine, you need to go get that
it's
checked.
not going down.
And it's not going down. You need to get that checked.
Yeah, and that can be easily checked. They can just do a dipstick and see if it's protein or not. Okay, if it's protein, even if your blood chemistries are normal, that means you have kidney disease. All right. So now another thing that would make you want to ask about your doctor about kidney disease, or go to and ask someone, is if you have a family history. See, these are the kinds of things that if you have them, they're like risk factors or keys to motivate you to get it checked out. Now, we have a lot of damage through medications. One of the biggest culprits is pain pills. I'm not talking about prescription drugs like opiates. I'm talking about things like
over-the-counter
Motrin, Advil, ibuprofen, Aleve. You know, those medications, some people tolerate them, but if you already have kidney disease, that will take your kidneys out very fast.
So can I ask another quick question? And this is for individuals who may have to get kidney dialysis or are thinking about getting it. Is the process painful as far as getting that dialysis? Is it painful?
Okay. Well, some people, I mean, you may have friends or relatives. You know, if someone sneezes, they're going to jump to the ceiling.
Yeah.
Okay. So some people, you know, are kind of hyperreactive. Some people have a very low threshold for pain. All right. The majority of the patients we have, and I said we're doing 88 to 90 patients, I would say maybe 10% of them really squirm a lot when that needle's being put in. Okay. And there are ways to offset that. But the majority of people, you know, used to it after time. They just get used to it. Now, one of the things that makes dialysis units better is the amount of people that have these shunts before they reach dialysis. So around stage 4, we want to prepare a shunt. And
when you say a shunt, what's a shunt?
So in other words, when you have dialysis, say when you have hemodialysis, your blood, you know, normally your blood is being pumped through your kidneys to get clean. So if your kidney's not doing that, and we're going to replace that function, so we have to take the blood out. It has to go through an artificial kidney, which is like a filter, and that blood is returned, and that is what happens. So the blood is pulled out through a tube, it goes through a filter, and it comes back. So it's recycling the whole treatment. Now, if you try to do a vein, like when you go and get blood drawn, that vein is too soft. If you put a needle in there and tried to pull a half a pint of blood through there every minute, it would collapse those veins, and it would suck, and it wouldn't work. So what you need is a large size blood vessel that can accommodate that flow. So what we now, the arteries can, because the pressure in the artery is basically what your blood pressure is. So say if my blood pressure is 130, the pressure in my artery is 130, but the pressure in my vein is going to be about 20.
Yes.
All right, so if you could put that needle in the artery, that would be good enough, but the arteries are deep, and you can't see them, so you don't want to go digging for an artery every time you want to do dialysis. So what we do is we take a vein from the surface and sew it onto an artery. That's why we called it a shunt. So now all of a sudden, the arteries.
Because my uncle had one of those on his arm. I now remember.
So the artery is blood coming out of the heart. It's being pumped out, and the veins is blood that's being returned. So the veins is a low pressure system. The arteries are high pressure. If we attach a vein to an artery, now all of a sudden that high pressure system is shunted through that vein, and if that vein's superficial, it will thicken and grow to be like an artery, but it'll be on the surface.
That's right.
So you have easy access to it.
Because my uncle before he passed away, he had that same type of vein in his arm, but the thing that happened with him is that he didn't have to necessarily go to dialysis. It was something to do with gravity, and he was able to take the he had a pouch, and I guess he would hang it on the wall, and the whatever was in the pouch would filter into his body, and then there was another drainage.
Yes, that's called peritoneal dialysis.
Okay, got you.
All right,
okay.
So in hemodialysis, you pull the blood out and it goes through an artificial machine, and that filter is like if you took 1,000 straws that were the size of your hair and you connected it to one end of that tubing, and that blood would percolate through those straws, and then you'd have it encased in a plastic container where your dialysis fluid would go through there and draw those chemicals out without actually touching the blood. In peritoneal dialysis, instead of bringing the blood out, you take that solution and you put it into the stomach, and in our abdomen, in our abdominal cavity, we have a lot of blood vessels.
Yes.
So you can put that fluid in your abdominal cavity and sit it in there. You usually put at least 2 to 4 quarts in there, and it'll sit. There are different ways you can do it. You can put it in every 4 hours, or you can put one in all day and at night cycle them through rapidly. But that's peritoneal dialysis.
WHCR 90.3 FM, New York.
Dr. Emerson, I'm going to have to cut you short because this information was getting very, very interesting. Vinny B, I thank you for giving us about 5 more minutes. But what I want to do right now is wrap up. So real quick,
announcements.
Well, actually, before we even give you announcements, Mo, can you please give our listening audience, as far as if they wanted to get more information, as far as can you give that number again, as far as who to call, who to call?
Yeah, our dialysis unit is 212-939-4848.
Say that one more time.
212-939-4848.
And where is that located at again?
That's at Harlem Hospital.
Got you.
It's in the Martin Luther King Pavilion on the top floor.
Got you. 18th floor, right?
On the 18th floor, right?
Got you.
Wow. If you have questions, we have a staff. We have social workers. We have a patient group, patient advocacy group that can answer questions that people may have. Especially if they're close to dialysis and they want to talk to somebody about it, find out how it is, kind of adjustments that they have to make in their life. We have a patient group that does that.
Excellent. Dr. Anderson, I want to, again, thank you for coming on to the show.